Today we're reporting on the New South Wales Ambulance Costing Study, a project commissioned jointly by New South Wales Health and New South Wales Ambulance. My co-presenter for this work is Susan Dunn from New South Wales Activity-Based Management. So in this project, we embarked on developing a classification system for ambulance services that can be used for activity-based funding as well as other purposes. Ambulance services have tended to be block funded, and this is even in countries where ABF has been well established. So this work is innovative in that it hasn't been done before as far as we're aware. With the rising demand and costs of ambulance services, there's a need to develop approaches that capture the complexity of patients using ambulance services and to reflect this in funding. So this paper is reporting on the initial phase of this work, an analysis of cost drivers of ambulance services, and a preliminary ABF classification ahead of a full costing study, which is planned for the next phase of work. For the project, we got data from New South Wales Ambulance for 4 years, and this was for a longitudinal view of ambulance activity and also to smooth fluctuations due to COVID-19. So just a couple of things to note about the data. One is that ambulance data is very complex. So the computer-aided dispatch or CAD system is an operational data source, and it's got many different timestamps in it as well as other operational data. Also, the electronic medical record data contains data about the protocols that have been administered, including medication protocols, and there may be any of these related to any particular incident. The second is that the aeromedical data is a separate source to the road ambulance data and also has its own complexities. But overall, New South Wales Ambulance has very rich data which can be used for things like costing studies without having to collect additional data. At the same time as getting the data, we undertook process mapping workshops with New South Wales Ambulance. The objective of these was to understand New South Wales Ambulance's work to feed into the classification development. The workshops resulted in specification of product streams of the activities of the ambulance service, looking at the scope of ABF and also units of count. So I'll talk about the product streams in a minute, but in relation to the units of count, we identified 3. The first one is an episode of care, and this is to be used for road ambulance activity. We define this as all activity related to the retrieval of a patient, including, for example, where there may have been multiple ambulances that were involved for any one incident. The second unit is an event, and this is not the retrieval of a patient, but the presence of New South Wales Ambulance at major events like Mardi Gras or New Year's Eve. And the final one is a journey, and this is for aeromedical services. So we did intend to use episodes for the aeromedical services, but we found that it wasn't possible to effectively join the aeromedical and the road transport data. Also, often aeromedical retrievals involve transporting more than one patient, and the costs are driven by the journey. So they've got the same staffing levels involved, even when there is more than one patient. In this initial project, what we were looking for were variables that we could use which could differentiate the activity from a resource perspective. So we looked at 3 variables. The first one is dispatch priority level, which is assigned in the call taking process. The second one is the nature of the problem that's identified by the call taker in that process. And then the third one is the clinical protocols that were implemented by the on-scene clinicians. So even though the nature of the problem and the clinical protocols used are seemingly the same, so they're variables that relate to the clinical profile of the patient, they are different in an important way. So the nature of the problem, as I mentioned, is assigned by the call taker at the time of the 000 call, and the clinical protocols are recorded on the scene by ambulance officers. So you can imagine there are many situations in which the nature of the problem is different from the clinical protocols that have been used. And this isn't just because of the different perspectives that are involved. It could be that the situation may have changed by the time the ambulance gets to the scene. The markers of resource use that we had in the data, because at this stage we don't have the costs, were episode duration. So we calculated this from the 000 call to the completion of the episode, and we added up all the times associated with multiple ambulances where there was more than one ambulance used. We also looked at the mean number of vehicles per episode. This is important as more complex incidents usually have more than one vehicle dispatched. And then finally, we looked at the mean number of intensive care paramedics. And this is also important as intensive care paramedics are dispatched for more complex cases. I mentioned the product streams, which were an outcome of the initial workshops, and these are listed here. So the second stream listed there relates to things like interfacility transfers, road ambulance transport of a patient to and from a flight, and also routine patient transport. And the fifth one relates to things like frequent user management program and training that's provided by New South Wales Ambulance to Fire and Rescue New South Wales. So we applied the cost driver analysis to product streams 1 and 3. For product stream 1, our high-level classes were based on how far the episode had progressed. So we differentiated classes where there was a call only and no further action. So, for example, the call wasn't related to an emergency incident and the person was referred to a more appropriate service. Then where an ambulance was dispatched but called off and nothing further happened. So, for example, where an ambulance was no longer required and therefore called off. Then where the ambulance arrived on scene and the patient was treated there and not retrieved, for example, where the ambulance officer was able to deal with the issue on scene and no further action was required. And then finally, when the patient was taken to hospital. Dispatch priority levels show differences in resource use amongst episodes in classes 3 and 4 of the emergency episodes, while the nature of the problem and the clinical protocols generally didn't. Where they did, the differences were already explained by priority level. Therefore, we further differentiated classes 3 and 4 for stream 1 based on dispatch priority at this stage. For aeromedical, we created classes based on the type of vehicle, as the different vehicles have specific staff and costs associated with them. And after analysis, we also recommended that they be further differentiated by priority level, grouped up in the levels that you see there on the screen. So this work reflects an initial attempt at an ABF classification for ambulance services. Further work is planned to undertake a costing study and potentially explore other factors driving cost. And there are opportunities for refining the classification in the future. For example, better aligning the aeromedical and the road ambulance data to create episodes where both of these resources are used for any one incident. So overall, the expansion of ABF to non-traditional areas like ambulance services is recognition of the benefits that ABF can have for matching funding to complexity and encouraging innovations to manage demand and costs. So here are our contact details, and thank you.